Good evening. I want to welcome everybody here to Central Health. I'm Mike Giesland, President and CEO, and we'll kick off this community conversation around the fiscal year 2020 proposed budget. So it is still, the operable word there is proposed. It's not final, and this is one of many opportunities that you'll have to provide comment. We are live streaming right now, so that way people that aren't able to be here can watch the proceedings. And to get us started on some ground rules and how we'll proceed, I'd like to turn it over to Ivan Davila.
Thanks, Mike. Hi, everyone. Ivan Davila, Director of Communications and Community Engagement, Central Health. Si alguien necesita traducción, tenemos aquí traductores aquí a la izquierda, así es que levanten las manos si alguien necesita traducción. We do have translation services in Spanish, so for those of you who need Spanish language translation, come over here. Other than that, the bathrooms are located outside these doors. Take a right, and they'll be on your left. If you need some water and some refreshments, please feel free to help yourself. Other than that, welcome and enjoy the community conversation.
And also, I'd like to recognize we have several of our board members here tonight, not a quorum. But we have, starting over here to my right, we have Dr. Charles Bell, Manager Maramu Saitef, our Chair, Dr. Guadalupe Zamora, and one of our other members, Ms. Cynthia Valadez, who is here with us today. So in the event that another board member comes in, we'll have to stop the proceedings and let Dr. Zamora announce a quorum to keep us compliant with the Open Meetings Act. So thank you for your patience on that. So I'd like to start off with a patient testimony that, you know, we get into a lot of data and we look at a lot of numbers and spreadsheets and we have meetings and conferences on healthcare data, but at the end of the day, will people remember the data or will they remember the stories that affected their lives? And I really like to think it's the stories that affected their lives. And here is Sara Moreno. She lives near Barbara Jordan Elementary. She was driving by one day and noticed the mobile clinic and popped in there to see, hey, could I get immunizations for my kids? And within 2 days, she had an appointment for her kids. And so I think this is a strong testament to, you know, different partners coming together, not just Central Health, and we'll talk more about that later on, and putting those dollars to good use in areas of the county so that Ms. Moreno can get her kids seen and vaccinated. It's something that's close to her neighborhood and easy for her to access. So that's important to us. But that's a strong story, and ultimately that's what we're driving for here. So there's a number of factors, and I'm going to talk about what's driving our budget and some of our thinking so that way you know everything that we know here at Central Health. And, you know, fancy yourself as somebody who's a strong patient advocate or just somebody who's just interested in civic affairs. Either way, we want you to have insight into what we have on our heads in terms of how we're going about forming this proposed budget. And then I'll hand it over to Lisa, who actually knows the numbers frontwards and backwards and can walk us through what the proposed budget looks like. But here what this graph shows, and it's from our demographic report, that we still anticipate double-digit growth in the number of families at or below federal poverty level through 2022. And as you can see, that's continuing on the eastern crescent of the county. But also there's points out further west that you see where we do have clinic locations out there as well. But the majority of that growth will occur in the eastern crescent. So our demographic trend hasn't changed. But then in addition to looking at places where people are and what their economic conditions are, we have to look at the overall volume. And so this is another important fact that we look at. And as you can see, since 2008, it kind of leveled out from 2007 to 2008, but since 2008, it's been increasing steadily in terms of the level of primary care visits that we provide. And this isn't, you know, just don't think of a primary care visit as it's the annual checkup. It's a lot of different services that are rendered in a primary care setting. And so as you can see, it was just shy of just a little bit above 500,000 encounters for 2018, but projected to be just below 600,000 encounters for 2019, this current fiscal year. So overall, while we're thinking about place and where people are and what their poverty conditions are, we're also thinking about the levels and the volume of care that we need to provide to people in Travis County. Now the question is, how do we do this? How do we focus on place and have the clinical expansions that we're working on, but then how do we increase that volume and care that you just saw? And it's simple. At Central Health, we have partnerships, so we can't do what we do alone. Right now, we have over 140 organizations, from nonprofits to clinics to hospitals and other health organizations that we partner with to deliver health and health care, and that's an operable phrase there, health and health care throughout Travis County. And in 2018, we saw over 180,000 individuals, and we showed you the encounters on the previous slide, but that translates into over 183,000 individuals each year. Now, shifting from some of the numbers and getting down to our mission and what our strategic objectives are. Up here on the screen are the strategic objectives that the board adopted a couple of years ago, and they're still relevant to where we're headed today. The first one is develop and execute a healthcare delivery model based on people in place. Healthcare happens all over the county. Health happens wherever people are, where they live, where they work, where they worship, where they hang out. And so what is it that we can do to meet people where they are, how they are? So that's people in place. The second objective is implement a patient-focused and coordinated healthcare system. You saw on the previous slide how the number of encounters was continuing to increase steadily since 2008. And again, I mentioned it's not just about the annual health check or whenever you're kind of feeling under the weather, you go in and try to get better. It's all the different types of healthcare services combined and trying to coordinate that as best we can, either in a place or in a system that really makes it seamless. And there's a whole lot that goes behind that. But the one thing that I'll mention about implement patient-focused and coordinated healthcare, our focus for the foreseeable future, because of the growth in families that at or below poverty level and the volume of care that we need to deliver, our focus in the future is going to be on access to care. And so everything that we do is going to look towards how do we fund the necessary levels of care to be able to provide access to care. If we don't take care of that very basic element through our partnerships, for example, then you can have all the cool ideas that you want to, but if you can't provide access to care, we are not using our strongest asset to address health disparities, to address health inequities. And so we believe very strongly that by focusing on access to care in the future, we'll make sure that we're bringing our best strategy to the table, and that is to provide primary care, specialty care, post-acute care, like when you get out of the hospital or you need additional care that's not appropriate for a hospital setting, but making sure that we're providing the full spectrum of care because we can help people address their health disparities in their lifetime, not just for future generations, but right now, today. So that's important to us. And then the third objective is sustainable healthcare financial models, and this is important for a couple of reasons. You can't do the first two if you don't have the third one, right? To be able to address healthcare based on geography, to be able to address a patient-focused and coordinated healthcare system so that we can provide access to care to help address the health disparities that are out there, help people achieve health equity. You can't do those two things if you don't have that third piece in place, and that's a healthcare financial model that's sustainable. A few things have happened since we last met, or since our budget was adopted. A lot of things have changed at the federal level and will continue to change that affect how Central Health funds care. Many of you are familiar with the demonstration projects under the Medicaid waiver. That funding will be going away in fiscal year 2022. That is a very significant hit to Central Health and to a lot of other providers in the community. There have been changes in the way that federal funds can be used to fund hospital care. There have been changes in the way that, or will be changes coming this October, in how we fund primary and specialty care and how we're able to leverage federal funds to fund the basic care that I just talked about. So you put all that into the soup and what do you get? A lot of change. A lot of change that is external to Central Health, meaning we didn't cause it, but instead of just sitting around and wringing our hands, we're using this budget to get out ahead of it, to make sure that we can continue to provide those level of services that we showed you earlier. And when you're talking, when we start hearing about the budget, and also we'll be presenting a budget book tomorrow, I believe, and it'll be available online. There'll be a few print copies that we can provide as well, not everybody all at once, but mostly online. You'll see a significant shift in our budget from this current year to what next year is going to look like come October 1. And that all of a sudden you'll see these big dollar amounts for primary and specialty care and post-acute care that typically you didn't see. Those were in our partnership budget with Ascension Seton. But with the CCC, or that partnership that I just mentioned, the Community Care Collaborative, going away as a funding mechanism, except for limited circumstances, all of those costs are shifting over to Central Health. So that's a big change for us, and we want to make sure that we have a sustainable financial model so that we can continue to keep up with some of these changes and what's happening at the federal level. The last thing I'll say about the changes that we're seeing at the financial model, we had a performance review that we kicked off in 2017. It was presented in, I believe, January, February of 2018 or early 2018. And this performance review noted that Central Health had a lot of strengths. We were different from other hospital districts, but we needed to look at two things. One, transparency in terms of how things are funded, and two, control. I think this new budget that you'll see, especially if you get into the details as it's rolled out and talked about in public hearings, gets us to a much greater level of transparency, because you'll be able to see, oh, here's what's being spent in Central Health on primary care, here's what's being spent on specialty care, on hospital care, instead of looking around at all these different budgets through all of our different partnerships that we have, trying to find what is being spent on what where. I think it brings it all together in a much cleaner fashion. The second thing that the performance review pointed out was control. And we are very thankful for our partnerships that we have with Community Care, with Ascension Seton. We're working on a partnership with UT School of Nursing out in the southeast part of Travis County. And the list goes on. There's 140 different partnerships, as I noted earlier. But by having more of the costs being shifted for primary care and specialty care over to Central Health, that gives us an opportunity that we currently don't have. And the performance review said control. I like to flip that and call it opportunity. We have some opportunities that we simply didn't have, or that we don't have right now. And I think by having those costs being shifted over, yes, it's a big change for us financially, but I think it gives us some opportunities to really do some great things and continue the work that we started in the Community Care Collaborative, going into the future and really making a difference in people's lives and being impactful, and not just another place that funds services, but actually funds real health and real health equity. So those are some of the big picture budget strategies and objectives, and just some observations, and I hope that they're useful to you. And at this time, I would like to turn it over to Lisa to talk about the tax rate and the budget.
Thank you. Well, I'm Lisa Owens, Vice President of Financial Operations. Thank you all for being here tonight. I just want to hit some of our highlights establishing our tax rate and our budget, and walk you through some of the numbers. As Mike mentioned, we do have a very robust proposed budget booklet. It is on our website tonight, and available for you to take a look at. Okay, so I see some familiar faces from our April meeting. So since then, we have been in a process with our Board of Managers to look at our long-term financial needs, what that means for fiscal year 2020, and what that means for establishing a tax rate for fiscal year 2020. So we do that through a long-term look. This year we looked out 7 years. As Mike mentioned, there's some programs that are changing in 2022. And what we're looking at with our Board of Managers is our reserves, and maybe making sure that we have the reserves to ride some future needs or prepare for some future needs. And so in working with our board and looking at those long-term forecasts and estimates, we have drafted our proposed budget with a proposed tax rate of 6.9% over the no new revenue rate. And that's a new term with all of us. It was formerly called the effective rate. And that means that it's 6.9% over what the rate would have been if there were no new revenue to Central Health. It does look at that rate and calculate it, and it is about $18 million in additional tax revenue, you'll see when I show you some of the numbers. But this, we believe, make sure that we have the long-term financial reserves that we need in order to meet some of the challenges that are with the changing funding model, as well as just the rising cost of healthcare and volatility in demand for services. So in establishing that tax rate, we have a maintenance and operations rate, which is the majority of our tax rate. We have very low debt. And so our maintenance and operations rate we are proposing will be 10.4906 cents per $100 of assessed value. And the debt service rate is 0.0667 cents per $100 of valuation. So a total combined of 10.5573 cents per $100 of valuation. And we like to look at how that impacts the average taxpayer in Travis County. Our boundaries are Travis County. And so we use information from Travis Central Appraisal District on the average homestead value, taxable homestead value. And we have a homestead exemption of 20%, a maximum allowable by law. So it looks at that average homeowner and what those exemptions might be and calculates what the tax bill would be. And so you'll see we estimate this average person in our jurisdiction might see an increase of about $23, so just under $2 per month, and that's the impact to the average taxpayer. You'll see if you check out our website and look at any of our presentations, we're presenting to our board almost every board meeting, and I'll talk through a calendar at the end. There's a lot more information there, and I'd encourage you to go to our website and get more information there if you would like. So we also like to look at how we compare to other major hospital districts. Every major city in Texas does have a hospital district now, and Central Health does keep our tax rate low. As Mike mentioned, we have a partnership model, which is unique. And with that means that we keep our tax rate low by not owning a hospital. We use a partnership model with Ascension Seton. But you'll see that compared to other hospital districts, we are not only the lowest rate, but also the lowest percentage of the tax bill. So an average homeowner in Travis County might have several jurisdictions that they're taxed on. For myself, it might be AISD, Austin, the city of Austin, Travis County, Central Health, and then ACC, for example. And that is just, our portion is just 4.3% of that whole tax bill. Okay, so looking at some of the numbers, we have up here our last year's proposed or approved budget compared to what we're proposing for this year. And again, we will go over the calendar, but we have lots of opportunities for input through our public hearings and presentations. We look at our budget sources and uses of funds. So majority of our sources are tax revenue. We have a little bit of lease revenue. As many of you know, we own 14.3 acres, the Central Health downtown property, and we have some long-term ground leases that generate revenue there, and that's estimated to be just under $14 million next year. And then a little bit of revenue from tobacco litigation settlement and interest, but the majority, just under $215 million, is estimated to be from our property tax revenue. So our total estimated sources of funds is $290.8 million. Our uses of funds, we have two programs. We have our healthcare delivery program and our administration program. We're very proud that our healthcare delivery is 96% of our budget, and we do try to keep our administration and tax collection low at just under 4%, just around 4%. And the majority is put into healthcare delivery. We increased our healthcare delivery year over year from last year's budget to this year by over 12%. And you'll see significant investments in healthcare delivery, which is intergovernmental transfers, which is a program that we use with the federal government to leverage a local tax dollar to bring in federal tax dollars, a matching program, as well as healthcare services. Mike mentioned primary care and different services that directly impact patients and the care that we deliver. And then healthcare operations and downtown property. We have a robust enrollment and eligibility program. We have premium assistance programs. And then we do have our downtown property, as I mentioned, that we are working on developing. And so there are some expenses around operating that property as well as the development planning. We mentioned this long-term look, looking out 7 years and making sure that we have enough reserves. And so one of the other areas you'll see on the sources and uses is this contingency reserve. That is in addition to 15% emergency reserves, and that is an available source of healthcare delivery dollars, but we need it for future planning. And so it's appropriated there for healthcare delivery. But it does help us ensure that we have the long-term reserves available to fund healthcare. And then finally, other reserves and transfers. This is predominantly reserves for our capital projects, which you'll hear more about in our budget presentations as well as in our budget booklet. Some of those capital projects are in Eastern Travis County. We're working collaboratively with a lot of partners to invest in clinical services and new initiatives in areas where there is not as much access to healthcare as we would like, as well as the campus reserves for capital. And then just making sure we have enough emergency reserves in our emergency reserves. So, and finally, our debt service. As I mentioned when I was talking about the debt service tax rate, we have very low debt service right now. It's just $1.4 million of those expenses. So our total healthcare delivery is just over $278 million in our budget. And again, our total administration, just over $12 million. Total estimated uses in our proposed budget is $290.8 million. So what's next? We started this process, I think, with many of you in April when we had a community conversation. We worked with our board on a long-term forecast. We shared a proposed budget with them, and this is the estimated no new revenue tax rate that we've prepared the budget with at 6.9% over that no new revenue rate. And our proposed budget is here tonight. We will be working with the Commissioners Court, who approves our budget and our tax rate, visiting with them in the next couple months. We will be hosting public hearings. We will have 2 of those. I think your handout has the dates, so make sure you spread the word and come back if you like. September 11th and September 18th. And then in late September, we'll be approving our budget. Our board will approve our budget and tax rate, the final tax rate. And then the Travis County Commissioners has the final approval on that. So we encourage you to stay involved. As I mentioned, our website has a whole page dedicated to the budget development. We have our proposed budget booklet out there. You can always look at last year's if you want even more detail. And all of our meetings are archived and available online, either live stream or you can look at the archives online. So we encourage you to stay involved. And with that, I'm going to hand it over to Mike. Back to Mike.
Thank you. So what we thought we would do tonight, and you all tell me if this works for you. If not, we'll figure something else out. But instead of asking questions as a group, some people may want to do deeper dives into the numbers on the budget. Lisa and I will be available to answer those questions. And back over here to my left, we have Sarah Cook and Dr. Mark Hernandez. Wave your hand, say hello. They can talk more about the program. So we talked about access to care and primary care and specialty care and post-acute, and didn't even mention pharmacy. That's $11 million. So I think they can answer a lot of questions about a lot of our work in terms of providing health care and the different projects and pilots that we have out there. So numbers, people, you can come up here and talk to me and Lisa, or if you want to learn more about the programs and the services that we offer and are planning on, then I would say Mark and Sarah in the back. We can just kind of divide up into, well, let's see how many people here. Yeah, let's go ahead and go over to the other room. There's enough people here. Commissioner, Mike. It's just Mike. No, it's just Mike. It's just Mike. Miguelito.
Just a clarification, so tomorrow y'all are presenting the budget to Travis County?
Yes, ma'am.
Okay, and then that'll be approved at a later date?
That'll be approved at a later date, yes, as will the tax rate, yes. Because it still has to be approved by the board ultimately, yeah. Yes, sir.
Why did you pull down the earlier meeting
It had in part to do with the timing of the tax rolls. We wanted to be able to talk about the tax rate, talk about the revenue side, as well as how we're going to allocate the funding side. And because of the delays in the tax rolls and getting the certified tax rolls in, we really couldn't speak with the degree of accuracy that we wanted to be able to say, okay, here's how much revenue it is, and here's what the likely tax impact on individuals in Travis County is. But that's why we want to be able to talk about it both at once. Yes, sir.
Respect to with your relationship with Seton.
Mhm.
They're one of the 140.
Mhm.
Are they the ones most impacted by the change from the federal government that is redirecting resources away, if I understood it, from hospital care?
It's not so much that they're redirecting sources away from hospital care. They're changing how you spend the money is the way I would like to think of it. And I think to answer your question, I would say that they are probably the most impacted in this market at this point. But I want to pause there. Do you have any insights that you'd like to provide on that one?
I think what Mike was referencing was the development in how the uncompensated care program works. And in locally, we have a new local provider participation fund. You'll hear reference to the LPPF, and that is just changing how the program works. But I can't speak to the financial impact to the hospital systems and what that means directly. But I can tell you that just how the uncompensated care program works is we have a new local provider participation fund, and we have a lot of information on our website about that, and we can speak one-on-one about that. But that LPPF is a new mechanism for hospitals in this area to participate in that program that is administered by Central Health as a administrator, but it is a CMS and HHSC state program.
Howard, let me come back to your question because I want to add to what Lisa just said, and hopefully it's fully responsive to what you just asked and informative for the rest of you as well. So the way that the funding is allocated has changed. That's the biggest change here. And so Lisa mentioned the LPPF. The way it works today, and I'm going to use pieces of paper in place of dollars, okay? So the way it works today is Central Health sends up some money, and down with it comes some federal money, okay? That's the simple version. Well, now what's happening is with this LPPF, and other hospital districts do this, this is not a new thing or something that's unique to Central Health, is now the hospitals are going to put up some of that money to bring down the federal dollars. Do you like my monopoly money that I'm using here? To bring down those federal dollars. Since we are not putting up as much match to bring down those federal dollars for the hospitals, we are now taking on more of the opportunity of providing primary and specialty care and post-acute care and pharmacy. So the dollars have shifted. That's the biggest change.
How do those dollars flow through to compensate providers?
Right. So on the hospital side, it's really done in the aggregate, meaning there's a big chunk of money that's provided to the hospitals. However, we're fortunate in that we're working with Ascension Seton right now to develop a claims-based system, and we're negotiating with them right now. And the idea being not just get several tens of millions of dollars, but be able to report back, oh, here's the claims, here's the individuals that came through the hospital that were medical access program or medical access basic program participants. And even though it's a zero bill claim, still having that claim data is going to be important because then you can see what levels of services are being offered in exchange for those dollars that are being transferred to that hospital. Now, individual providers for specialty care, primary care, et cetera, those are going to be just as they are today through contracts that we have with those individual provider groups, and they're reimbursed. The vast majority of our dollars are reimbursed on a value-based system.
Is the bottom line net the same with Ascension Seton as it has? I know that's been a contentious
Yeah, I'll have to go
controversy in the
back
past.
and look at some of the calculations, but I don't know that it's a net to Ascension Seton. I think and I would say this about other hospital systems, all the hospitals are still carrying a lot of uncompensated care on their books.
But the relationship between Central Health and Ascension Seton has not changed at the bottom line?
Well, we're talking to Ascension Seton right now, but both of us are being, in light of the federal changes that I just laid out, we're having to redo our current working relationship that we have now and our current partnership agreements that we have now. And I think overall, you may see us providing more cash outlays just because of the increasing costs in hospital care. But that's a function of economics. But still, you take into account all the other federal fundings that they receive. In addition to, you adjust what you pay in locally based on those federal fundings that are available.
Okay.
Mike, we have about 20 minutes or so for Q&A before we move on to the group discussions, if we're okay with that.
Okay.
Okay, and the reason I'm passing out the mic is because this is being live streamed, so be sure that I give you the mic, please.
Well, I'm not sure that I need the mic. I wanted to ask about actually looking at this is my first meeting coming, and
Welcome. Glad you're here.
I am glad to be here. I am interested in the partnerships that Central Texas, that you all have, specifically with nonprofits. And I am a founder and executive director for a nonprofit that works specifically with people that have gone to prison and their families. And I think that when you talk about access and equability and disparities, this is definitely a population specifically to Black and brown people, but increasing every day with other ethnicities, that has definitely been looked over and that doesn't have accessibility and not even the ability to speak and know what to even look for in healthcare. And I think that that's real important, that that's inclusive in the conversation and whoever you all are partnered with, because I can tell you that there is a whole niche of Travis County and City of Austin residents that are not able to have, that are not able to sit in this room and even understand about access in healthcare and what they need. And with many people coming out of prison right now already addicted to drugs because it's a pass-through in prison. We also need the thought process about, how can I have partnerships with residential treatment facilities, but the cost for that is astronomical. And so what do you do about those people that are coming out that are already addicted? Those people that are coming out who went into the system with herpes and all different kind of STDs and that are coming back out into the community and have never even seen a doctor. So I have this that hits my office. I came from Bastrop County into Travis County, and our office is located on 15th and Trinity. But I'm just saying this because I recognize that many people that have this ill have not had the ability to even be seen by a doctor, and I just feel like that's something that needs to be.
And duly noted, and I think, when we break up, I think it'd be worth a quick conversation with the folks over here, with Sarah and Mark, because there's a lot that they can answer about what we do, and quite frankly, what we need to do better in terms of folks making that transition coming out of prison. I will say this, is that if you or anybody else has a nonprofit group that is working with people that are transitioning out of prison, it's just a phone call to us so we can talk about how to connect them with our enrollment and our eligibility services. I mean, because the first step is getting them on some type of program, most likely medical access program, but we also look at what other programs are out there that they might qualify for. But I know there's all kinds of limitations for people that are coming out that have records, but we still like to take a look at it and see what it is that we can do. But I think getting people connected with that first step, and people think, well, that's enrollment and eligibility, it's not really the healthcare process. That is very much part of the healthcare process. The enrollment and eligibility is just as seeing a doctor or a nurse is, because that's access to care. when you get right down to it.
Mike?
But I appreciate your comments too, because there is a disproportionate impact, disparate impact on people of color that are incarcerated for a variety of reasons, some of which, involve institutional discrimination, and duly noted.
Mike?
Thank you. Yes, ma'am.
As you know, my name is Gloria Leal. I'm an attorney here in town, but I'm here on behalf of LULAC Council 650 and LULAC District 7, which encompasses the councils in the Travis County area. And I was asked to comment to you that we're interested in your continuing support for, and you talked a little bit about having some funding and making sure that regional disparities are addressed. For example, we're very, very interested that Central Health continue to make progress on the Del Valley Clinic, so we'd like an update on that. And number two, we continue to support the funding of the Sendero program, which is like a last resort for indigents in this city. So we'd just like to bring that to your attention and to make sure that it's addressed on the budget.
Thank you.
Thank you.
And if you come over here to talk on the number side, you'll see we can talk about the amounts that we have for premium assistance on the Sendero side. We're going to continue that program. That's in our proposed budget. That's a priority for the board. And then a continuing priority for all of us is of the four focus areas that we have in Eastern Travis County to push either towards opening this fall, or in the case of Southeast Travis County, we're continuing to work with UT School of Nursing in the Emergency Services District out there in terms of reaching an agreement. And we anticipate bringing something to the board soon, we hope. But that also in Eastern Travis County, and I want to point this out, and this is something that you'll see in the foreseeable future. There's a lot that we can do even before we get the bricks and mortar out there. So we're currently using the Travis County Employees Clinic a couple of days out of the week with expanded hours, I think up to 7 p.m. or maybe even later. Yeah, and then Saturdays we have hours as well. And again, I'm speaking specifically to Southeast Travis County. We also offer rides, and the zip codes out there that are bound by 71 on the north and 130 on the east, those zip codes constitute some of our top areas for rides to and from Southeast Health and Wellness Center. So we're able to connect you with providers at the Southeast Health and Wellness Center. And then we also have a mobile clinic that's in Creedmoor 2 days out of the week. So there's some things that we can do as quick stopgap measures in the meantime before we get bricks and mortar on the ground. But we're absolutely committed to continuing that project, making it happen with bricks and mortar. Thank you. Yes, ma'am.
I've noticed that when things are in certain areas of Austin, the Southeast, Del Valley, Creedmoor, the curb appeal is also lessened. Where people are not even, it doesn't feel like an invited situation because of what it looks like. It's not enough dollars. I mean, where Black people and brown people are, the reality is it doesn't seem that there is emphasis put on where we go for treatment and what it looks like even. And I've noticed just in my business, and I won't be long, I just have to put these points out because I won't be able to stay, but I just feel that when you are even talking about, I have people somebody that just came in today that needs treatment for residential treatment. There are hardly any facilities available that are here in the immediate Austin area, and if they are, the price just for entrance is astronomical. And so I really feel like
Talking about mental behavioral health.
yes, I'm talking, and I'm talking about substance abuse.
Right.
That basically goes hand in hand. And so I think that when you're talking about a healthcare district and some of the things that should be priorities to you all, first of all, is to really look at the disparity on just curb appeal on how people are treated of color and look at what that looks like. And then the fact that there's not enough information, the information flow is terrible when it comes to people of color, and especially people that have gone to prison. So I really want to say that that's not my experience because I've had insurance all my life. But this is the experience of the people that I represent for the last 15, 16 years, and I just really feel like we need to do something.
And I appreciate you saying that. Let's talk about curb appeal for a second. So I'm going to call them temporary or stopgap measures. They are just that. It's designed to get something out there quickly and get it set up, where we've ordered a modular, for example, a modular clinic for the Hornsby Bend area. And, but long term, and we've also just recently closed on a piece of property out there that is 10 acres. But the long-term solution will hopefully address that curb appeal. Now, curb appeal means different things to different folks, but well, the way I look at it is, you know, when you walk in, and who's the professor at UT that does the race and architecture tour? Who is that? Gordon? Ted Gordon, yes, thank you. He really does a good job of walking through architecture and showing this is how this affects people of different ethnicities and different races and gender identities in terms of, is it inviting or not? And in a perfect world, I realize different people are going to have different perspectives, but if you look at our Southeast Health and Wellness Center, and we have board members here that were very active in that and trying to develop that, but making it culturally not just appropriate, but inviting. And because we want to build that level of trust, we want to build that feel so that you want to go into this place because you genuinely believe you're going to have a good healthcare experience. And that's just on the architecture side of it. And then on the provider side of it, it's being able to build that trust over time. We realize it's not going to be in the first visit, but being able to build that trust over time so that you're willing to trust your healthcare with those individuals. I mean, ultimately, long term, you know, when I hear curb appeal, that's kind of what pops into my head, but tell me if I'm missing it, because, okay, all right. Appreciate your comments, thank you. Okay, so for those of you, and I'm really going to pitch the numbers one because I'm afraid everybody's going to flock over there hearing about all the cool stuff, right? And I get that, I understand that. But if you want to talk about numbers, come up here at the front of the room. If you want to talk about programs, we're going to go next door. We'll have Central Health staff over there to guide you. So you don't wander out in the parking lot, but you make it into the right room. And then we'll walk around and kind of wrap up the session here. But we really appreciate you all coming out, learning about our budget, asking questions, telling us what you support, and really addressing some just issues that need to be talked about very courageously. So thank you. Yeah.